This video describes a surgical technique of identifying and repairing ramp lesion through anterior portals in a 24-year-old patient who underwent left knee revision ACL reconstruction. The clinical assessment revealed a positive Lachman's and anterior drawer test. The knee MRI showed ACL graft tear. The MRI also showed a ramp lesion seen in both sagittal and coronal cuts. The surgery is done under general anesthesia with the patient in supine position. With a thigh tourniquet, the operated leg is placed hanging off the table. Diagnostic arthroscopy revealed a cartilage damage at medial femoral condyle, which indicates a chronic medial meniscus injury. Next, the arthroscope was advanced to the posteromedial compartment through the intercondylar notch to look for the meniscocapsular tear. To identify the lesion, the arthroscope is positioned at meniscocapsular junction and using suction to drain fluid from the joint, followed by pumping the fluid at the junction. The pressure of the fluid at meniscocapsular junction can accentuate the meniscocapsular separation, as in this case. Medial release is performed with a knee in full extension and valgus, which is performed by an assistant. A needle is introduced medially over the MCL, slightly distal to the medial femoral epicondyle. The medial collateral ligament can be released percutaneously while the assistant maintains valgus stress. The degree of medial release can be controlled by looking at the amount of medial opening through the arthroscope. The ramp lesion can be identified by using a probe to check for a gap at meniscocapsular junction, an increase in medial meniscus translation. We start the repair by refreshing the edges of the lesion at meniscocapsular junction by using an arthroscopic rasp to remove fibrous tissue and obtain vascularized edges. First, we repair the meniscocapsular ligament in vertical suture configuration. The FosTFix 360 device from Smith & Nephew is introduced through anteromedial portal using a slotted cannula, with arthroscope in the anterolateral portal. The device penetrates the capsule to deploy the implant posterior to the capsule, and then penetrate the superior surface of the meniscus to close the posteromedial meniscocapsular gap. The second FosTFix 360 device is introduced next and posterior to the first stitch. The first needle is passed through the capsule and second needle passed through the meniscal tissue. The third all-inside device is passed more posterior and again introduced in the capsule and meniscus in vertical configuration. This vertical repair can be repeated in the same manner depending on the length of the ramp lesion. The surgeon can observe the closure of the gap during suture tightening. The right lower picture shows the meniscocapsular gap before the repair of the ramp lesion. The upper picture shows the gap has closed after repair of meniscocapsular ligament. Next, the meniscotibial ligament is repaired by introducing the reverse FosTFix flex needle to the undersurface of the meniscus. The first needle is curved up and passed through the body of the meniscus, and the second needle is passed down to the meniscotibial ligament. Tightening of the knot will push the meniscus down to the tibial plateau. A probe can be used to check the final stability of the repair.